Recording. So hi everyone, my name's Jenny Fitzharding. I am one of the volunteers for National Education Alliance for Borderline Personality Disorder, and I just really wanted to thank you for making the time today to come along and learn a little bit more about these very important topics that we're talking about today. And I want to acknowledge the lands upon which we're all meeting. I'm over in Perth on Wajak Noongar country, and I just want to acknowledge all the traditional custodians of country throughout Australia and their connections to land, sea and community. And we pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So just a brief introduction to NEA-BPD. Our primary aim is to support families and carers of people living with a personality disorder.
Just Musa from the wellbeing team.
Sorry, hello. Can somebody please mute their phone, their speaker? Thanks.
Yeah, I'll continue to say.
Sorry. For some reason I've
Jenny,
lost
don't worry, I'll
yeah.
do that for you while you're talking.
Thank you. Thanks very much. I know there's a mute all button and I couldn't find it for a second there. Yeah, sorry. So the NEA-BPD is we're here to support people who are supporting people with personality disorders, and borderline personality disorder, sometimes referred to as emotionally unstable personality disorder, is one of the most commonly diagnosed. It's a complex diagnosis, and it can certainly wreak havoc not only on the people who are experiencing it, but also the people around them. So we have more than 200 volunteers right across Australia, and we're one of 26 countries around the world that offers the Family Connections program, which is a 12-week evidence-based program that provides skills and hope to family members and carers. It's a free program and it's led by volunteer leaders, most of whom are family members as well. We receive no government funding, and we're entirely reliant on donations. So to those of you that could make a donation today, we really appreciate it. And if you haven't had a chance to do that and you can afford it, you know, even $25 is hugely, hugely helpful. For those of you that submitted questions, we'll have a short Q&A at the end of the presentation. You can also put questions into the chat, and we'll try and get through as many of those as possible. And we'll also put in a donation link. Please keep yourself muted during the presentation. Sometimes you can jump off mute as well, which is catch you by surprise. So just keep an eye on that for us. And now I'm going to introduce our fabulous presenters who are giving their time. First of all, we're going to hear from Dr. Louise McCutcheon, and then we'll hear from Susan Preece. Dr. McCutcheon is a clinical psychologist and senior program manager at Origin, the National Centre of Excellence in Youth Mental Health, and the Helping Young People Early, or HYPE program, and the Origin Youth Health Clinical Program. She's also an honorary research fellow at the Centre for Youth Mental Health at the University of Melbourne. Dr. McCutcheon has coordinated the clinical program at HYPE for 11 years and established the HYPE Service Development and Training Program, the first to offer training in cognitive analytical therapy in Australia. She works with mental health services, assisting them to implement early intervention for BPD, and lectures and teaches both nationally and internationally. She's the founding chair of the Australian and New Zealand Association of Cognitive Analytic Therapy and secretary of the International Cognitive Analytic Therapy Association. And Susan Preece also works at Origin in the HYPE clinic, and she's a team leader of family peer workers. She's a senior family carer consultant there. So I will hand over to our presenters, and I'm really looking forward to hearing what you have to say.
Thank you very much. And I'll just see if I can share my slides. that look like it's got the right view for you? Jenny, just give me, yeah, great. Okay, well, thank you for that introduction. And I guess we were invited to talk a bit about early intervention. So that's what we're going to focus on. I'll give you a bit of background. People might have seen previous webinars that I've run for NEA BPD or in other forums. So I'm sorry for the overlap. I've been working in early intervention for 25 years now, so I'm pretty passionate about intervening early in personality disorder, so that's where we're going to start. I do want to also acknowledge the traditional owners of the lands where I am. This is the Wurundjeri people of the Kulin Nation in Melbourne. So Origin is a specialist clinical program. We're funded by the state government to provide public mental health for young people aged 12 to 25. And we have a catchment area of 1.3 million people. We service all of severe mental health problems, mostly through an outpatient specialist stream of care. So they provide early intervention for psychosis, as well as personality disorder and mood problems, eating disorders, neurodevelopmental disorders, so many different streams of care. And we also run acute and subacute programs. And I think what is important about Origin is that we've had this integrated research program that's been able to conduct research within our early intervention programs that help inform really the rest of the world in terms of helping understand personality disorder as it emerges in young people, and helps to clarify and understand better what treatments might be helpful for people in this age group. So that was what the Helping Young People Early program has been developed for, to provide a clinical program, but also to integrate research. And my role has been knowledge translation. So that's talking about the research, but also the clinical wisdom over many years of working with young people with these sorts of presentations, and thinking about how we can assist people in other places, in other areas, and as well as the families and carers and supporters of young people as well. So I want to kind of pull together what we've learned over the last 3 decades or so about personality and personality disorder, and how those things have changed and our understanding has changed over that time. This is really just an introduction, because the language is starting to change, and that can be hard to keep up with if you're not familiar with those changes. So just to start at the beginning, we all have personality. We all have words that we use that describe the characteristics and the behaviour that makes us who we are. Well, those things are what connects us to other people and make us similar to other people, as well as what differentiates us and makes us unique. And we all know that life is unpredictable, and that we need to be able to be flexible and adaptable to manage the ups and downs of life. And when we talk about personality disorder, we're really thinking about the aspects of a person's character and the way that they relate to themselves and others, and the way they respond to the world around them, that makes it harder for them to manage the life's ups and downs. And our classification systems have changed quite a lot in the last probably decade, I would say, and obviously preparation for those changes before that. But really now what we're moving towards is a way of understanding personality disorder that doesn't break personality disorders up into different types, that thinks much more broadly as personality disorder as one idea or one concept, but that people can present with mild difficulties or moderate difficulties or more severe or extremely severe difficulties. So we won't be talking about the different types of personality disorder nearly as much. We are still holding on to the idea of talking about borderline personality disorder in order to be able to identify the people that we would have talked about in research. But really the overlap between severe personality disorder and borderline is now pretty much established. And so mostly what we do in our program is talk about severe personality disorder. but we also work with people with milder versions of that as well. So the language is going to be changing. We won't be talking about borderline personality disorder nearly as much, and eventually that will move away. When we think about what are the core features of personality disorder, it's really about the way people relate to themselves, so self-functioning and interpersonal functioning. And if we think, what do those things mean? We're really talking about identity and the capacity to manage oneself in order to be able to work towards goals and think about the kind of person that we want to be. And when we're thinking about interpersonal functioning, we're thinking about the capacity for empathy and also the capacity for intimacy, how we manage our intimate relationships and how well we can do that. And those things are very much the core of personality disorder in our understanding. And when we are making a diagnosis as clinicians, we'll be focusing on those particular areas to make a diagnosis. We'll be assessing how well people manage their relationship with themselves and their relationship with others. And then we'll be looking more broadly at how those difficulties are displayed across different areas of life. So how they manage their emotions, how people can think and respond rationally and reasonably when under stress. Can they see their own situation clearly like others can see it? Or are their interpretations of what's happening for them more distorted and different from others around them? And then we'll be looking at their behaviour and whether they can manage their impulses or whether their behaviour is matched to the situations that they're finding themselves in. And when they're not, we're thinking much more along the lines of personality disorder. So I hope those things are relatively clear for people. That may be a shift that you haven't heard of before, or it might be something that you have heard of already. We're moving much more towards those systems. I think in Australia, we're probably a bit behind what's happening in the rest of the world. Certainly my colleagues in Europe and in North America have already moved to those newer systems, and those assessment protocols are different now. So I think Australia will be moving in that direction. I also want to just remind us all that that personality disorder is a developmental disorder, which means we're always thinking back to what are we expecting this person to be able to do, or what are we expecting of their relationships according to their age or their developmental age. And we're also understanding that personality disorder is a cultural concept. So it may not apply so well to people who've grown up in different contexts. And when we're thinking, for example, about people with First Nations background, we just need to be mindful that it's a very Western concept that expects people to be, autonomous and, function very independently. And that's what we hold up as, well functioning. And I think the other thing is that when people are struggling earlier in their life, so if we see them having difficulties managing the ups and downs of life early on in their lives, that can really have long-term consequences. So we also want to be able to notice when people are getting stuck in, I think vicious circle is probably the best way to describe it, where they're attempting to cope with things that are not working so well for them, but they're getting a bit trapped in that vicious circle and things are actually getting worse and worse rather than they're finding their way out of that. And so why we want to be noticing personality disorder early on in life and in this sort of youth age group is that it can really lead to very long-term difficulties down the track. And I'll talk more about that in a moment. A brief footnote, which is that most of the research that we are drawing from has been focused on borderline personality disorder. But as I said, the features of borderline personality disorder and severe personality disorder are pretty much the same. So we can use that research, even though we're shifting our language to severe personality disorder. So we'll be using those terms fairly interchangeably. Some of the research will be very specific to that group of difficulties, and some of it will be more general. So why do we need to detect it early on? Well, the first thing is that personality disorder in young people is very common. It's particularly common in clinical settings. Approximately 10% of the population will have a personality disorder at some point. Severe personality disorder is around 3% in the community, and it's usually about 50-50 if you measure it out in the community in terms of male and female. But what we see in clinical settings is that around 20% will be presenting with severe personality disorder. And if you included the people who are presenting with more moderate sorts of symptoms, then that number will go up. And what we also know is that in general, females tend to present more to clinical settings than males. So the numbers are usually around 70 or 80% female, roughly around that. But because it's such a common problem, whether or not it's being diagnosed, the clinicians and clinical services will be seeing young people with personality disorder features. And why we want, or why we argue that people need to be able to be responsive and detect personality disorder when it's present, is that if we look at the population of young people who have personality disorder compared to those who don't, those with personality disorder have much higher distress, significant impairments in self and interpersonal functioning. That's not surprising because that's what we use to measure it. And they're much more likely to have extreme or inflexible personality traits. So they're struggling more to shift and be flexible and adaptive when they need to be. They're much more likely to have high levels of current mental health symptoms across the board. That is the high prevalence sort of difficulties like depression and anxiety, as well as, other sorts of issues, particularly substance use, eating disorders are common. So there's a whole range of things that people might be experiencing. They're more likely to have poor physical, sexual and reproductive health. They're more likely to be dropping out of education, employment and training. They're more likely to be at risk of being a victim or a perpetrator of interpersonal violence, of non-violent offences and of family violence. And quality of life scores are lower than for any similar age disease group. So that really tells you how poorly they're doing. They would be rating their quality of life as poorer than someone who has cancer. And we know that personality disorder is among the leading cause of disability across the lifespan. We also know that people who care for young people with personality disorder are usually struggling as well. They report greater negative experiences of care, fewer positive experiences of care, which means that they don't get the break and have those joyful moments that with family that kind of keep you being able to keep struggling when it's hard. They have higher levels of expressed emotion, which is an idea that is about the level of conflict and hostile kind of talk and verbalizations in the family. And those experiences are rated as worse than the caregivers of young people with first episode psychosis. So they're experiencing a lot of difficulty as well as the young person. We're going to come back to family involvement later. The other thing is that it's not just current difficulties that people are experiencing, it's also that personality disorder acts as a gateway to future difficulties. So we have quite a lot of research now that indicates if you have diagnosable personality disorder features, even one feature in your adolescence, you are more likely to have difficulties going into adulthood. And those difficulties are across a very broad range of domains as well. That means the risks of other mental health difficulties, a whole range of mental health problems are more likely. Poor functional outcomes, and I'll come back to that because that's a really important outcome of the research over the last couple of decades. They're also more at risk of being either a perpetrator or a victim of violence, poor educational, vocational outcomes, and increased healthcare costs. And those differences are already statistically detectable at age 20, and they persist for at least 2 decades. So even if someone grows out of or no longer has a diagnosable personality disorder, if they had that in their adolescence, they're much more likely to have persistent difficulties into their adulthood, sometimes for decades. So that's why we argue so strongly for early intervention. If we are not picking it up and not addressing it, then those difficulties are much more likely to persist. I did want to come back to that idea of functional outcomes. And this is an old study now, but I think it's really a very dramatic picture to look at, that if you follow people up with borderline personality disorder, but we can think severe personality disorder, over 10 years, the GAF is a global assessment of functioning, and 50 is a low score. That means these people were not functioning well across all of the domains of functioning that they measure, which is about their relationships and their activities and their work and educational kinds of outcomes. These people didn't really improve over 10 years. They stayed poor for at least the decade. And there's no, it's highly likely that they went on functioning poorly. And these people, some of them had treatment and some of them did not have treatment. So the important thing to take away is that if we don't attend to functioning outcomes, they won't get much better unless we deal with them or tackle them specifically. And of course, there are other serious concerns that we also need to take into account, and that is that the suicide risk is approximately 10%. That's very similar to the early psychosis figure. People are more at risk of suicide early on in the lifetime of their personality disorder, and their life expectancy is reduced by 2 decades. So we really want to make sure that people are understanding that personality disorder is a severe mental illness for many young people. The other thing I want to say is that we now have quite good evidence that the best time to detect and intervene in personality disorder is in people's youth. So we know that the reliability and the validity of the diagnosis is very similar in adults to young people, that there's no real difference between the diagnosis. We know that significant disorder usually emerges in this youth age range. That's part of our understanding of personality disorder. We know that it's common, and we also know that it is associated with high burden of disease, morbidity, and premature mortality. And yet, we also know that many clinicians feel very reluctant to embrace the early diagnosis and the treatment. And that's what we're most concerned about. If we look at populations in clinical settings, what we can see is that the detection rates are 10 to 20 times lower than would be expected. When we look and we ask people about personality disorder, the rates of diagnosis are much higher. So what we can say is that mostly what happens in our clinical settings is late intervention rather than early intervention. We put off making a diagnosis. That means we don't offer the specialized treatments and the kinds of treatments that young people want. Sometimes we even turn people away from our services, and we don't address personality disorder until late in the course of the disorder. We often have, very limited access to treatment programs. We kind of silo personality disorder away from everything else, and that makes it much harder for people to access. And we wait until the problems are really well and truly entrenched, which is also concerning. So we just quickly think about why is it still a controversial diagnosis, especially in young people. Mostly what we can see is that that there are a whole lot of unhelpful beliefs and myths about personality disorder that continue on in our healthcare systems. And the first of those is that you're not allowed to diagnose personality disorder under 18. That is not so at all. And the DSM has only ever had some very minor constrictions around what personality disorder you can diagnose. And what they have recommended is that we're careful and thoughtful about our diagnostic processes with under 18s. And of course, we should be careful and thoughtful. That should be part of what we do with everybody. What we've seen is a shift in the last 15 years to our diagnostic manuals being very clear that we should be detecting personality disorder when it is present, whether the person is under 18 or not. And the DSM-5 definitely says that, and so does the ICD and all of our other guidelines about personality disorder care. So we have Australian guidelines which came out in 2013, and they clearly said we should be detecting personality disorder early. The second one is that personality disorder type problems are part of normal adolescence. And I guess what I would say is that we now have quite a lot of evidence that actually they're not part of what is usual, that the group that the sorts of behaviours that young people with personality disorder display are much more extreme, significantly different. Their onset is earlier, they're much more devastating than the kinds of behaviours that are associated with the normal trajectory for young people. And so those things are really clearly not the case. Personality disorder is not treatable, or alternatively is only treatable with long-term psychotherapy, or the focus of treatment should be on self-harm and not anything else. And what we know is that those things are unhelpful thoughts about personality disorder, that actually we have more than 3 decades of research that shows that interventions are helpful for most people, and that we can have good outcomes for people who engage in our treatment programs, and that we have a whole lot of different kinds of treatment which are effective. The other thing that's emerged from the literature in the last little while is that psychotherapy may not be the magic answer that we thought it was, that actually simple treatments can have just as good outcomes as our complex and long-term psychotherapies, and that's particularly the case for young people. The other concern that often is raised about the diagnosis of personality disorder in young people, or as a reason why we shouldn't diagnose personality disorder, is that perhaps other sort of understandings are more helpful. And, you know, I think a common example of that is that perhaps people have complex trauma or complex PTSD or emotion dysregulation difficulties, and that we should be calling personality disorder those names instead. I think our view is that both of those suggestions as alternate names are problematic because they exclude a whole group of people. About a third of young people, and actually adults as well, do not report trauma in their background. And so we would be excluding those people if we changed the name to complex trauma. And the same sort of argument can be applied to emotion dysregulation. Unfortunately, there are people with personality disorder who don't experience emotion dysregulation. So we want to be careful about using other terms because they exclude the people that are suffering at the moment. The other thing I want to say about the name and the whole arguments about the label is that I think that's a distraction from the issue of what are we going to do and how are we going to make our treatments available to the people that need them. When we get caught up in what we should be calling it, actually we're then off on a whole tangent, and we put a lot of energy into that rather than thinking about how we should be talking about what are more helpful ways of responding to people with these difficulties, and how do we help them have better lives? And of course, the final thing that most people are worried about, and appropriately so, is stigma labeling and the life sentence. And that, you know, if we diagnose personality disorder in young people, we've sentenced them to, you know, forever be persecuted. And I guess, you know, that is a problem that comes back to the healthcare system. Most of the stigma associated with personality disorder is perpetuated in healthcare settings. And so our clinical workforces need to take responsibility for that and change that. We would argue that's not a reason to avoid making a diagnosis, but it is something we definitely need to be working on. So what should early intervention be focused on? What we know at the moment is that over the last 4 decades, we haven't changed our treatments terribly much. We've mostly put a lot of effort into evaluating and offering complex psychotherapies as interventions. That means that they're very specialised, they're seen as very complex, and often clinicians feel they don't have the skills to be able to offer those treatments. And that means that they're left feeling like they have no skills to offer. It also means that those treatment programs are usually small, they are restrictive in terms of their entry criteria, they're often office-based, and they require the individuals to be able to access a whole range of different kinds of treatment all at once, and those things just all reduce the number of people that can access them. And I think they're also, generally speaking, fairly limited in their capacity to address psychosocial problems and to deal with the co-occurring things that are going on for people. So we're not really very good at focusing our treatments on functioning, and they require young people to be able to come into services and to be able to, you know, attend on a regular basis, to be able to do things as well-functioning adults would. And actually, young people with personality disorder often can't do those things yet. So many of those treatment programs are difficult for young people to access. And we would argue also that they're not really targeting the things that young people and their families most want changed. And they are things around social connectedness and relationships, improving the way a person feels about themselves, education and employment, and their quality of life. So when you ask people what they most want from their treatment, they're the kinds of things they say, and our treatments are not yet very good at prioritising those issues. Unfortunately, most of our treatments focus a lot on the psychiatric symptoms, which is what clinicians think we ought to be doing or treating. They focus on things like self-harm and suicidal ideation, and those things are sometimes the priority for our clients, but not always. Some people will say, actually, if I had better relationships and I had a job, I wouldn't care if I self-harmed. As long as I'm not doing something really dangerous, that actually works for me. So I think what we need to do better is to be able to consult with young people and make sure we're working on the goals that make sense to them. And often they are things, much more practical things. So in our view, the complexity of early intervention for personality disorder has kind of been exaggerated. It's been focused all the time on the psychotherapy being the answer rather than really practical care. What we do know from our research, and not just our research, but from the research across the world, is that structured clinical care can achieve very similar outcomes to the brand name psychotherapies. Our one was called Good Clinical Care for young people when we developed that. Now we call it Relational Clinical Care, and I'll say what that is a little later. There are other models that are very similar. General psychiatric management was developed in the US, and structured clinical management was developed in the UK. So both of those versions are attempts to be able to provide much more practical and less intense treatments that will be accessible to more people. And I guess this is another way of thinking about it, that the specialised therapies like DBT and MBT and all of these other three-letter names, these are the specialised psychotherapies, and we're certainly not saying they shouldn't be offered or they shouldn't be available to people, and many people get great results from those. The problem is they take a while to train people in, and their programs are usually small and intensive, and they probably should be saved for the people who most need them. And we should be able to think of brief interventions, crisis management, and good quality case management to be able to offer to the majority of people. So I'm just going to quickly tell you a little bit about the HIGH program and what sort of things we do in our program. We have 4 kind of priority areas that we try and work on improving. And so the first is interpersonal functioning. How can we help young people have better relationships? And that includes things like communication and thinking about, you know, their assumptions about relationships, what they hope for, and how can they actually put into practice some relational skills. We think about educational and vocational functioning, because once you have bumped out of a pathway, it's very hard to get back into that pathway. If you have left school early in your adolescence, then you're going to be behind for a long time, and it's going to be hard to get back. So we really want to keep people engaged in educational and vocational pathways, and where they have dropped out of those, re-engage them into those. The other thing is that there might be, we know that people are often distressed when they're coming to our services, so we do want to keep some focus on the mental health difficulties that they are experiencing, but we want to understand which of those are important for the young person. So we don't want to assume that a clinician's view is the right view. We want to be able to have a negotiation about which of those difficulties we focus on, because of course we're going to have to make some priorities and choose some of the goals to work on first. And then there's a much more general goal about enhancing health, well-being, safety. So this is the capacity to be able to look after yourself. And of course, what that looks like for a 12-year-old is very different than what we might hope that looks like for a 25-year-old. So it needs to be developmentally appropriate, but we're working with a group of people who are in the phase between childhood and adulthood. And so we want to really help them move along that pathway while we're working with them, and also as they move out of our care. These are the principles of relational clinical care. These are really not rocket science. What we're hoping is that all clinicians, mental health clinicians, will be able to do many of these things. We also acknowledge that sometimes simple things are not always easy. And if we think about some of the features of personality disorder, for example, interpersonal functioning, some of those difficulties are highly likely to come up in our treatment with people. They're going to be the difficulties that the young person is struggling with. So even just our first point about setting up a good working relationship, and thinking about who does that mean with. It means the young person, it means the family or whoever there is around them and working with them and supporting them. But we can expect that some of that will be a little bit rocky at some times, and that we might have some challenges come up in our work with them. But what we're hoping to do is really set a foundation that then we can work on inviting the young person to think about what they want to change and what they might want to work on in a time-limited way with us. And then we worked a lot on developing a shared formulation. So the formulation is the kind of narrative that we construct about why the young person is there and what they want to work on with us. So it connects the history that we understand with the presentation now, and then opens up options for how that young person wants their life to look and how we move towards that. We won't be able to do everything all at once, so we do need to somehow and sometimes make clear priorities about what we're going to work on in our time together, but that doesn't mean the young person can't be thinking forward to, and then I might work on that with someone else or later in my life. And the shared formulation is really important between the clinician and the young person, but also making sure that everybody else can come on board with that and understand what that formulation is, because that is the story that makes sense and connects why we're going to do the work that we're going to do, and makes sense to the young person why they would put some effort into thinking about what they want to change. The collaborative management plan is really just setting the goals and actually working out what are we going to work on, and it might be that that process involves quite a lot of management of crises. We all know that sometimes people are really in a very chaotic state when they come into a service. It might be started by an inpatient stay, for example. So we might have to do quite a lot of safety planning really from the very beginning and thinking about risk management. But the idea of keeping functional goals on our agenda is really important. We don't want to get distracted by the risk and the safety planning and that become the focus of all of our care. That actually that doesn't help us then do any planning and work towards how do we make your life better? How do we make your life satisfying and interesting and engaging? How do we help you thrive in your life? And that if we can work towards that, it's much more likely that the need to feel to engage in suicidal acts and self-harming and all of those other risky behaviours, those are much more likely to drop off if we're clearly working towards making life better. We talk about therapy as being an optional kind of icing on the cake idea, that some people will engage in therapy and want to have some therapy and others won't need that. What we're hoping is that when people say they can, that we can offer small contracts of therapy and try it out. But most often we want to keep the idea of functional goals in front of us because all of our clinicians can do that work. And then we know that some people are sensitive to endings and things like that. So we want to be mindful of that and make sure we talk about those things from the start, and that we always think how we can build supervision into our plan, which helps us all stay on track and then work better with the challenges when they come up. I guess I just want to end with this idea that access to services is really important for people with personality disorder. We see it as a social justice issue, that actually everybody with serious and severe difficulties should have access to treatment and to clinical services to support them, and that staff not having a brand name psychotherapy shouldn't be a barrier to getting some treatment. And then I was going to start to talk a little bit about families. I'm also aware I don't want to cut Susan off, and so maybe Susan, I'll just stop talking and you can go from there. What do you think?
I actually think we should open it to questions now, given the time.
Okay.
And if there's anyone who's got any questions about from the carer perspective, which I know a lot of you do, yeah, please bring them up, and Louise or I will address them. But thanks, Jenny. I think it'd be good to take questions.
Yeah. Okay. So you're not going to present? Yeah. Okay.
No.
Great. All right. Well, we do have a bunch of questions. Some of them I think were answered in the
good
in there. Okay. I guess it's just helping to clarify a little bit on the diagnosis stage. Somebody was asking, you know, what are the key criteria that really does warrant a diagnosis of personality disorder in youth? So what are the known reliable symptoms or markers? You've certainly answered that, you know, that there are no barriers to to diagnosing early. But is there anything, you know, that sort of is like
Well,
that hallmark, you know, raise the red flag moment that you'd say, yeah, this definitely needs addressing?
I think the challenge is that we're moving from a system that used to focus quite a lot on behaviour, and it measured the number of times you self-harmed and were you having angry outbursts, and, you know, did you behave in a, you know, an unusual way when you were scared of abandonment and things like that. So it was a very clear sort of, you know, tick box kind of exercise. And I think what we're moving towards now is an assessment that focuses much more on how the young person relates to themselves and how they relate to others. And we're still capturing the behavior and difficulties managing emotions and all of those things that we were assessing before, but we're asking slightly different questions. And I think assessment of personality disorder is more challenging than it is to assess something straightforward like depression, where you ask about a 2-week period and it's just yes, no, have you experienced this? We are asking about patterns of difficulty over a period of time, and we would argue over a couple of years. And if somebody has co-occurring difficulties like depression, that can make it more challenging. However, it's really important that actually people feel that they are capable of making personality disorder assessment. And if they don't feel they can do that, they should get some training, because actually it's such a crucial issue that we should be assessing. So I think if you feel like people are not adequately assessing your young person, then I would go to someone else who and get an assessment done again. I'm distressed when I hear that people aren't feeling like they get adequately assessed, and I can agree that there's still a lot of myths that clinicians hold on to, that you can't make a diagnosis in people under 18, but those are myths. They are not accurate. And if you Googled the DSM yourself, you would be able to, you know, show clinicians the part of the guidelines or the DSM that say that that is appropriate. However, there is still a lot of stigma and, you know, unfortunately discrimination that occurs, and we can't force clinicians to do something, you know, that they won't do. So I would find someone else.
Yeah, but which is great, except it is very, very hard to get in to see people. So
Yes.
how are you addressing that with you know, obviously in your bio it says that you're responsible for training clinicians.
Yeah.
How is that going? Because, you know, like we're an army of, you know,
Yes.
clinicians and carers who know this. We know that early intervention is great, and we know that there should be no barriers to early diagnosis. But you know, you're arguing with people with a lot of power.
Yeah, that's true. And some of them are, you know, in positions where they direct services and run teams and things like that. And I think there have been some really wonderful steps towards making a difference in terms of creating Australian guidelines and different states setting up personality disorder services that run across their whole state. In Victoria, we have one. In South Australia, they have them. So, you know, not all states yet have those, but in some states they do. I would probably be thinking about how you can lobby more effectively by getting in touch with those sorts of organisations, the personality disorder services in the state that you live in, and seeing how we can lobby better. I think also the carer and consumer kind of groups are also incredibly powerful. People's personal lived experience is very, very valuable and very persuasive. So I think I would be encouraging people who feel you know, concerned about this to think how that could be coordinated even more effectively. I think it's already made a difference, but I think that we could do better with that.
Yeah.
And
And in your clinical experience, are you finding that more, that you are getting more psychologists and more psychiatrists that are interested in this new way of approaching personality disorders?
yeah, I think it's an area that's opening up and that people are feeling more and more confident. If the training that we run is more and more popular each year, and as people feel more confident in their capacity to offer simple interventions, even when it's challenging, and they know where they can get support for that, that makes them more likely to offer services to young people with personality disorder. But it's also a patchy thing across Australia, still very patchy. There are some states where personality disorder is well understood and much more commonly accepted and detected and intervened with in under 18s. And there are states in Australia where, unfortunately, that is less common. So we have plenty of work in front of us. I think, unfortunately, we can think of other kinds of clinical presentations where there are wonderful role models speaking out loudly about neurodiversity, for example, or, other mental health problems. And we don't have passionate advocates who speak out as clearly for personality disorder. And that is probably due to the stigma they experience, that it doesn't feel comfortable to say out loud, I have a personality disorder, or I was diagnosed in my youth with personality disorder, and these are the things that I learned. We have lots of bits of video of young people saying those things on our website, but, it's a different thing when people then get, much broader exposure. And those people are individuals who are not yet well known, they don't have high profile personas. So,
thank you. Susan, can I throw one to you around, it's a general question that's being asked in a lot of different ways in the chat. How can carers support their young people, in this gap of waiting for care or finding the right care, or what's the most effective thing you can do?
That is
This
such
is
a massive
hours
question.
of conversation, I know.
Exactly, but I can
yeah.
talk from the chat, and I've worked with carers of people with personality disorder for long enough to know that people are exhausted often by the time they get to help. So if I was just to say a couple of things I think are helpful, one is to join some sort of advocacy or lobbying group, as Louise has suggested. It's not only good politically to get involved to change things, it's also very supportive to be with other carers who feel the same way and have had similar experiences, and that's quite normal to feel this way in this situation. The other thing I would encourage after years of working with people who love someone with a personality disorder is to do as many courses as you can on communication, whether it's tuning into teens or it's, the local government might be running something on how to communicate, how to validate people's, emotions, how to know when to quit and walk out of the door, those sorts of things, which we think we know as family members, particularly parents. But I think I wish, looking back in my role as caring for someone who was unwell, I wish I'd done more work on myself. Because in the end, if we can't get these treatments and we can't get the help we need, really we can't anyway force our loved one to change. It's up to us to change and to learn the skills to know how to manage this over a long period of time so that you don't burn out. So I'd say, learn about communication as much as you can, and join some sort of lobby group where you can feel connected, as in Family Connections, but free plug, Jenny. But, there's being involved in something where you feel you fit and you can affect change as well.
Yeah. And I will say that we've got so many webinars, not only on NEA BPD Australia's YouTube channel, which talk about how to validate. There's some fantastic webinars with people with lived experience talking about how they, as a couple, have navigated having a personality disorder in the relationship. So please check those webinars out as well. And NEA BPD US, which is the original NEA BPD, they have so many webinars on, going into particular skills and things like that. So, yeah, there are some good resources out there in that way. And also, every state has carer organisations. So in Western Australia, we've got Helping Minds and Carers WA. There are, in Victoria, there's Spectrum. I don't know what's in New South Wales. Is anyone in that area? And the BPD Foundation has got a whole list of free or government and not-for-profit services on their website, which I will poke in the link once I've asked another question. Let me find you another one. There have been some questions about heritability. Is there a genetic component to it? Is there something, and just general, I guess, physical aspects of a personality disorder? So by that I mean things like, hormone. Someone's asked about the hormonal cycle and how that can intensify personality disorder symptoms. Is that what you would call it, Louise? I'm not sure if I'm using the right terminology there.
So maybe it's useful to talk a little bit about the causes of personality or the etiology, how it emerges. And our understanding is that some things are genetically inherited. So we have a temperament when we're born. That's different from our siblings' temperament. And some of the features associated with that will be inherited. Like we can say things like, a quick temper. You can see that passes through families, and that often there are generational patterns that we can see. So we know that there are some aspects of personality which are inherited and which make our risk of struggling with the ups and downs of life a little bit more, tricky. That doesn't mean you're definitely going to develop a personality disorder. That just means you're more vulnerable to struggling more with life's ups and downs. And then we have, the experiences and the environment in which we are raised, in which we grow up. And sometimes there's a good fit between the carers and the child, and we seem to find it easy. And then there are other times when our own fit as a parent doesn't fit so well with our child, and there might be many, many reasons why that is. It might be that we are unwell, or that we are struggling socially or physically or with whatever, that may mean that it's hard for that fit. It's hard for us to be tuned in to our child's needs and to be able to respond when and how often the child needs us. So there might be some fit situations that make it tricky. And there might be also things that happen to a young person that make it hard to see oneself as powerful and directing one's life, and being in charge of one's life. It might make that child grow up feeling like everything is difficult or always a challenge. So there's also the interpretation that we have of our experiences. And I think that's actually quite important, because we know that children can grow up in the same family, and yet their personal experience of growing up in that family is quite different. So our understanding of what happens to us and our understanding of why we are the way we are and what our opportunities are, and whether we fight hard when things get tough or give in when things get tough. All of those things shape the way we manage. And when we get to 12 or so, when we go through puberty, all of those things are beginning to play out in a way that we can say, okay, this person is really struggling compared to other people around them who potentially are more able to adapt. They're more flexible, they're more able to get on with others, they're more positive about themselves, and they can manage themselves through those challenges of life. And when someone's struggling, that's when we're starting to say, what exactly is going on for that person? Do they have a particular mental state problem, like depression, which might come and go and prove challenging for, at different times? Or is this much more a long-standing pattern of the way the person is coping? And when it's that kind of description, that's when we're looking more at personality disorder. So I hope that makes sense. It's a complicated thing. There's genetics, there's environment, then there's the way that we understand what happens to us, and all of that combination means that, we'll be on different pathways, and some young people will have very similar risks but end up with maybe things going well for them when they get a little older and can kind of move out of their environment perhaps, or, get into an environment which is more nurturing and encouraging of them. It might be that other people in a similar sort of situation find barrier after barrier after barrier and have many challenges. And, some of those people, we might say, have a mental state disorder. They might get depressed, or they might have anxiety difficulties, or something that we can treat and it goes away. And other things might be much more like personality disorder, which is sort of ongoing challenges, and people have to really relearn ways of coping.
Yeah. Thank you. That's a great potted summary of how we get there. Susan, I just from a carer perspective, one of the themes that is also emerging is, when your young person is in crisis, you want to get them into hospital, you want to get some support, you need a break, and the services are turning you away. Any tips for advocacy there? Is that, like whether it's reaching out to advocacy groups like Comwa, or I don't know. Sorry, you probably.
Yeah, look, you've sent a list around supports, which I think is probably the best for people to follow up. But I would say building your own team, because often you may have spent years building a team for the young person that supports them. A lot of whom may have fallen through and not been helpful, but you've strived to do that. I think what's important is to build your own team as well. And often those two teams can overlap. So, for example, a grandparent could often fall into the in-between time and in-between overlap, and they would be a person who can support either side. But building your own support team by joining some sort of carers group is really important. Taking time out if you can. I know that's easy to say if you're a lone parent who's, running the show and having to take on a lot of responsibility. But I think those times of reflection and taking yourself out of the situation as much as you possibly can be really helpful. And I think not feeling guilty about doing that for yourself, and really saying this is a way to keep the whole family standing. And I think it's important that siblings are heard. It's important that a lot of people can be heard. I guess some of the work we do at Origin is really coaching families, for example, grandparents and parents and siblings, to look after themselves and try not to take sides within the family about what the behaviour that's going on, but try and step back a little bit and get some perspective. Tap into some free carer counselling if you can tap into that. And so, those ways of helping you survive and thrive, given that this may not be like psychosis. Sometimes you can have an episode and then things go quiet for a while, or potentially indefinitely, whereas this is something we need to be in for the marathon, not the sprint, and to look after ourselves that way.
So who would you have on your team?
My team, I was privileged to have a partner whose mother was unwell. So he had some really inbuilt, hardwired ways of living with someone who's unwell, which always encourages me with when I see younger carers or siblings, and the family thinks, oh, they, you know, they'll be traumatized for life. But really, sometimes loving someone who has personality disorder can actually be a training ground for persistence and compassion and lots of other great things that we build in ourselves. So I have a partner. My son's sisters were fairly supportive, but they had their moments. I think my own psychologist who would support me through that. And also finding a psychiatrist with a carer perspective and interviewing them before you go to them about what are you, and a psychologist who will care for you as a carer, but also challenge you and upskill you with the skills you need to manage this, as I said, for a longer period of time. And you interview a psychologist like you would interview any recruit in the ways that these are things that you do, because not every psychologist does everything. And that's why particular carer counselling can be particularly helpful. So they're the sort of people I would reach out to on my team. I would reach out to, for my son's grandparents to be involved with him. They were not helpful for me. So, you know, you can also help place people and coach your family members or friends to understand what personality disorder is, and for them not to be frightened to support the young person or yourself. So I think that's important.
Yeah, great. Thank you. I think, you know, having practical you know, examples is really helpful for people. The other question that is coming up is about, you know, given that some clinicians are reluctant to put the label out there, you know, what do you do if the young person completely rejects the label, or maybe the label's been disclosed to you but not to others, not to them, and, you know, where would you go with that sort of situation?
Yeah.
I hope that made sense.
Well, I guess I'd say something about that. The label for its own sake is kind of not the point. We use diagnoses to help us think about treatment and responses, interventions. What's going to be most helpful for this person? What do we know already? And what does the young person want? So I think I would rather not get into an argument with people about whether or not they have personality disorder. What I've found helpful when I'm talking to young people who have in the past been told they have personality disorder, but then come into our program and say, I don't know about that, I didn't like that, or it was an unpleasant experience and I don't know what that means, then my process would be to have a conversation with the young person about the difficulties they're experiencing and look together at the criteria of personality disorder so they can see what we're thinking and why we're thinking about it. As a label, it's really only helpful to be able to think, so therefore, what do we want to work on? And I think from a clinician's point of view, you know, they may see that as, oh, okay, well, we don't have to make a diagnosis. I think the value of making a diagnosis is it makes sure we don't forget how serious this problem actually is. And if we don't help people get on to a more useful pathway, developmental pathway to adulthood, that actually they can kind of get pulled off track, and that can have long-lasting consequences. Having said all of that, it's also important that people actually want to engage in treatment or intervention. We can't force people. You can't make people change what they're doing. So I think it needs to be an invitation. And an invitation means that sometimes people say, no, I don't want that right now. And that needs to be okay as well. If we're truly going to give people support to change, then we need to know what it is that they want to change, and they need to have a really good idea about why. They need to be clear about that. So helping people think, hopefully, about these problems can change. And if we don't do something about them, probably they'll just continue, and that may not be helpful. But it has to be up to you, and it has to be something that you see some value in. So I work with clinicians a lot about how do we help this young person understand and discover for themselves what would be valuable about changing. And so the idea of diagnosis and the idea of intervention is all about what would make your life much better than it is now. You're clearly distressed. You're clearly not having a good time right now. What could we work on together that would shift that would make a difference for you? And if people feel more aligned, like the clinician is actually on their side working towards something they want, then they're much more likely to engage with us and to put in the effort that is required. Because actually we are asking them to change, habits that have developed over years and ways that they've understood, or tried to cope with life's ups and downs that have worked a bit, maybe. Most strategies work a bit, but they're probably not the most effective strategy they could be using. And so what we want to be able to do is invite people in a way that sounds tempting, that sounds interesting, that sounds engaging, and, invite them to work with you as a coach. Now, can parents do that? That's a hard thing for parents to do because you've already got a slightly different role. And so I think parents can open up the possibility of engaging with clinicians or engaging with services that might support them. If they're not interested in mental health, then try some non-mental health services. Anything practical that helps people do better in their relationships, engage in education and vocational pathways more effectively is going to be helpful in the long run. So don't give up on those ideas. Don't think that mental health is the only option, and don't think now is the only option, because actually we have quite a number of people who vote with their feet, say no thank you to your program. But then if we've made it clear that we want to support them, we want to hear back from them when their time is right, then they come back. And at that moment, they're more likely to engage because we've had a positive experience early on and let them make a decision, trusted them a bit that they can make some decisions for themselves, but then we've welcomed them back again, and they are more ready then to put in the time and effort to change things.
Can I just add to that too, that as Louise said, that we've spent often years developing the person with personality disorders spent a long time with developing habits that work for them. It's the same with families, that we have developed a lot of habits relating as a family that is often hard to break. And that's why I do think we need outside support. So reaching out to whoever you think might be helpful, whether they're BPD focused or, as Louise said, they might be something, a course around parenting or listening skills, or just something that you can use to maybe break that nexus of poor communication skills within the family and friends.
Yeah, because people often get scapegoated, and that's part of the resistance to the diagnosis, isn't it? It's like, yeah, okay, I'm the one with the personality disorder. It's all my fault.
And I guess what we really promote is that people are doing the best they can with what they have. And what we want to do, though, is
including parents,
move up from there and build even better skills.
Yeah, and the parents are doing the best they can with what they've got as well. Yeah, exactly. We've got a question about, does marijuana play a role in increasing?
I think often what I would consider is that substance use ends up being a coping strategy that people are using to manage mostly their overwhelming negative feelings. Most people who feel really depressed or horrible might be angry, it might be upset, it might be, depressed, who knows. But substance use is a very quick acting strategy. It works, in
short term.
It works quickly in the short term. And the problem with it, though, is that it doesn't address what made you angry or what made you distressed. So it doesn't really fix the problem. It just covers up the symptoms, doesn't it? And so we would consider substance use is most often used like that. It's a way of treating the problem or covering up the problem, dealing with it. And it does work, so that's why people keep doing it. But of course, it leads to further difficulties. So when we talked earlier about that idea of vicious circles making their problems worse, that's a really good example of a coping strategy that actually ends up making the problem worse. Instead of just having personality disorder, they have personality disorder and an addiction. So can see that that's a very, that's an unhelpful strategy at the end of the day, even though it makes sense and we can understand why people start doing that.
Yeah.
Is that enough of an answer? Does that answer
I think
that
so.
concern?
Yeah, I think we've pretty much covered. Oh, hang on, there's a new message here. Oh, thank you. I think we've covered most of the questions that have come through in terms of thematically, at least, and if not the specific ones. I just want to reiterate the oxygen mask message. That when you get on the plane, they say put your own oxygen mask on first, and then you can help others, so that you don't collapse before you can help anyone. I think that's the hardest message for a carer to hear, but it's also the most important one. That you really do need to take time out and ask for help and get help. And there are really good carer organisations out there. Actually, it's easier to access care, support for carers than people with the mental health issues sometimes. And in that, having worked in one of those organisations, I can honestly say that when one person in a family changes the way they interact with the family members, the whole system changes. So even if there is a more, intense problem seemingly occurring, and your general fatigue, I can't, I'm at the end of my tether, may not feel as urgent or as needy, actually addressing that will really, really help your person.
Yeah.
So please.
And I think too, Jenny, absolutely, that worn out nature of the carers around someone who's unwell, but also if you're here today as someone who is a clinician or working in an organisation, not only the early intervention, but also whatever way works for you intervention. So whether it's phone, online, outreach, out of hours, all the things that clinical services are not used to. But sometimes exhaustion is so huge. And I have a colleague in this situation where she was just so exhausted that the team really needed to go to her and visit them at home. So I think, a lot more lateral thinking about how to reach out to those families.
Yeah, that's great. One last question. I think, does personality disorder improve with age?
Oh, I'm so glad to get that question at the end. That's wonderful. Yes, it does. And so the natural history of personality disorder is that people improve over time. The difficulty is when people are engaging in a lot of risky behavior, we need them to be not too suicidal. We need them to be alive to be able to get better. So if you do nothing, things will gradually improve. What we see, though, is that often the functioning doesn't improve much. So people can still be having difficult lives even though they don't meet criteria for a personality disorder. And what we most want is for people to thrive. So we really want to work with people to make sure that all of those areas and domains of life that would be fulfilling, their activities, their engagement with other people, their work, all of those things that they do, their sport, their leisure activities, all of those things we need to work on as well, so that those things also improve.
Yeah, that's right. And sometimes accepting that it may just be that the path to functioning is one day a week volunteering in a op shop.
Yeah. I think the other question that is, what age does it improve? That's an impossible question to answer. There isn't an answer to that. It is individual. And some people will improve much faster than others. There will be some people, a small number of people, for whom the difficulties are immense, and they continue to be immense for a long time, but that's a small number of people. The majority of people can improve over time and faster with intervention.
Yep, definitely. Thank you so much for such a really fantastic presentation. I know, you know, sort of getting front loaded with all the difficulties sometimes for families that are living through it can be hard, but it is really important that that information is there, that you know that it's not just you that's there, and that it's certainly that there's a whole cohort of clinicians and researchers that are, you know, really getting that argument out there that we really need early intervention, early recognition, and that will greatly improve the trajectory for young people and their families. So, you know, thank you so much for that, all the work you're doing, Louise. And
You're welcome.
Susan, yeah, thank you for all the work that you're doing in supporting carers. And yeah, and I would just add, if you're a carer, you being the first person in the family system to get helpful support may be the first step towards you, a young person, getting support as well.
Yeah. There's also resources on our website, Jenny. I don't know if you can put that in. I can't type in.
I can.
So
Yep.
www.origin.org.au. And we're just about to release a whole lot of new resources that have been developed just in the last little while, video clips and things like that about how we might talk about personality disorder and support for family members and things like that.
I'm just thinking off the top of my head in the last 5 minutes, 3 questions that you might ask a psychiatrist. You know, are you in favour of early intervention? Are you in favour of involving families in the treatment? And, you know, what are the outcomes that you want to, or how do you work collaboratively with a young person's outcomes?
Yep.
I don't know.
Right.
That's off the top of my head. I don't know if you've got better questions that you might ask, Louise, but from what you've told me today.
Yeah, they're good.
Yeah.
Yeah, families have a right to be involved. And so I would, you know, make that assumption and then ask how. How do you involve families?
Yes. Yeah, brilliant. All right, well, I'm going to stop the recording now. Thank you so much, everyone that came along, and yeah, spread the word. This recording will go up on our YouTube channel. It'll be up on our website. It might take a week or so to get up there. I'm not sure exactly how that happens, but it does. And share the link when you get it, and share it with your treatment team if you have one.
Thank you,
because the more the word gets out there.
Yeah, thanks everyone for your involvement and interest.
Yep. Thank you.
Bye.